Hi. Today I'm going to share with you an interesting case. This will give us the opportunity to really look in multiple angles, like one patient, but the discussion about this patient will give multiple, you know, um, interest arising, leads to learn newer topics. So let me get straight away into the, case. So this is a 70-year-old approximate diabetic, patient who has diabetes, hypertension, and he was admitted with us because of worsening cognitive functions. Like he is not walking well, he is not talking to people around him well, and it's been happening for almost a year, and but it's worsened from last 15 days. So family members were concerned, and they got him to the hospital saying that he's not walking and talking well, and diabetes, hypertension, right? And patient is bedridden, difficult to examine him. He's not cooperative. When he is conscious, he can listen to what you're saying, but when you ask him to sit, move hands, move legs, he's not doing that. And or if he does that, he does that inconsistently, right? So shortly, like this, I'm not going to, this is not a class where I'm going to tell you all the signs and findings and all those things. You're going to directly get to the points and get the some interesting details out, which can support you in learning at your own speed. Okay. So this patient, my diagnosis with this patient was multiple infarct dementia or multi-infarct dementia. Okay, so confirmed by the MRI image which showed multiple infarcts, lacunar infarct, multiple places. So that was that, and we were managing his hypertension, diabetes, and started routine treatment for ischemic stroke with antiplatelet drugs. And now the interesting part in multi-infarct dementia is, though the name is like that, they may not show absolute features of dementia, like as you see in Alzheimer's disease. In Alzheimer's, dementia will be the prominent system. In multi-infarct dementia, the memory loss, all those patterns may not be the prominent one. Whereas the immobility or they being bedridden, unable to move hands and lips, like those what we call focal motor deficits, they could be the presentation of multi-infarct dementia. Now that part is done. Now what happens 2 3 days later? Like we see, like the patient one day is taking deep breaths, and he's like taking deep breaths as if like he's putting extra effort. And I asked the relatives what happened, and he's saying like the patient has been breathing like this since yesterday evening. Okay, late evening, and we noticed this, but we thought it's just like he's just breathing, so we didn't take it very seriously. And in the morning, when I see him like this with this deep breathing, this is a concern. It was not normal and suddenly shows up in a patient. No, remember, he has multi-infarct dementia. That's all. Nothing else was there, and we are managing diabetes, hypertension. We check the sugars; they're in the normal range, not exceeding much. So this is ruling out acidosis because of some decay, something like that. And I check his pulse; it is having tachycardia. So now, few concerns. The patient is around 70-year-old. So these are the patients who, when they get new infections, they don't have temperature increasing, like fever, which helps body to fight organisms in elderly. If you want to look at the age group, maybe above 55 years, their immune system may not be consistently causing fever every time there is an infection. So there is a term called afebrile sepsis. So this patient's worsening confusional state, that deep breathing pattern, which we call as Kussmaul's respiration, as well as the tachycardia, was an indicator for afebrile sepsis. And we gotten a few tests done. The ABGA, arterial blood gas analysis, revealed lactic acidosis, and the complete blood count revealed leukocytosis, which was pointing to the infection. And when before the reports came, we had started him on empirical antibiotic, and his fever had come down with that, like with the breathing pattern altered, he was a little better. He started speaking, responding to relatives better. So that was one thing which The antibiotics starting at the time might have helped the patient. So this is one more way of picking this afebrile sepsis. Like patient will not have temperature increase, like how you would see in a normal fever. So it's afebrile and sepsis, confirmed by the total count increase and patient's response or recovery route followed by antibiotic. Now there's one more thing that you can anticipate in such patients, which is a recurrent CVA, like one more cerebrovascular accident that might have occurred. Now in this case, the tachycardia, is something which is on the other side. Usually, if there is a new infarct, if there is a hemorrhagic or ischemic with raised intracranial tension, then we see something called as Cushing's triad, which has hypertension. So this patient was hypertensive. So if you check the blood pressure, if it is on the higher side, 140/90, it doesn't reveal. It may be taken as one more thing, but it's not that, because in Cushing's triad you can expect BP shoot up, up to 200 systolic blood pressure. That didn't happen. Next thing is they will have, of course, they will have respiratory abnormalities, like their pattern will alter, um, and mostly they'll be irregular. But in this patient, he had a regular deep breathing. And the third one was the patients will have bradycardia in Cushing's triad. In this patient, there was tachycardia, which was pointing to afebrile sepsis. Okay, so there are multiple things we spoke. So let me just highlight a patient with multi-infarct dementia develops infection presenting as afebrile sepsis. And the confusion that could have arisen was if you are suspecting a new onset stroke, but the Cushing's triad was not consistent with the it didn't patient did not have findings which was consistent with Cushing's triad, so we can ignore that also. So I hope this patient with multi-infarct dementia, afebrile sepsis, lactic acidosis, hypertension, diabetes, um, and Cushing's triad discussion helps you to get a picture of kind of patients, fragile, elderly when they come, what and all may happen. I hope this information will somehow be useful to you. We'll meet you soon with another information, another patient.